Okay, so we'll just talk about a little bit of the pathophysiology and the perinatal, and postnatal management of congenital diaphragmatic hernia. So, starting off with so we'll dive into this, the pathophysiology. So, if we first start with the incidence, so actually the prevalence is 2.3 children out of 10,000 live births are affected with congenital diaphragmatic hernia. However, these numbers are often muddied a little bit. There's a lot of hidden mortality in the sense that kids that are die after birth and don't have the diagnosis are not counted in those 2.3, as well as some Western countries have allowance for termination of pregnancy if a prenatal diagnosis is made. So that's our best estimate in terms of numbers. When we talk about CDH, there's two types typically. The Bogdalek, which is the posterolateral type of CDH, the large majority is also the clinically most severe or most, I would say, interesting CDH phenotype, as well. And then you have the Morgagni, which is the anterior CDH, which we will not talk about during this talk, or at least not in my slides. When we talk about Bogdalek, so the posterolateral CDH, we have two types. You have a left-sided, again, the large majority, 85%, versus the right-sided hernia, which happens in 15%. They are phenotypically different, and we can talk about that in a little bit, mainly because of the organs, the difference in organs that migrate into the chest. About half of the patients is purely CDH, is isolated without a chromosomal abnormality or cardiac structural abnormalities, but half of them are associated with severe other defects. If you look at the pictures below, you see on the left side, you see a normal development of the diaphragm, which is a beautiful fusion of different layers and different structures. And so on the right side, you see that the failure of fusion between the septum transversum and the pleuroperitoneal membrane mostly caused that a diaphragmatic defect. In terms of etiology, so it's thought to be a combination of genetic and environmental factors that contribute to it. And so some of the genes that have been correlated with CDH are GATA4, LONNP1, and SOX7, but they are also heavily involved in chromosomal and major structural anomalies. If we then look at so CDH itself, so you have a diaphragmatic defect that allows migration of the abdominal organs into the chest. And as you can see on this picture, you see there's small bowel, there's stomach content, as well as the left liver is herniated into the chest, where they compress the developing lung and heart, which are by consequence hypoplastic. And so the pathophysiology of CDH is mainly a constellation of airway, pulmonary vasculature, and cardiac abnormalities. And if we look at the airway, so the lungs are hypoplastic, they're smaller, they're less alveoli, and the alveoli that are there are thickened and smaller in size. So there's less surface area of the alveoli that allow for oxygenation and ventilation. The vascular component of the lung. So there's I think of the musculature as being stiff and rigid and hypermuscular. So you have a vasculature that is not able to accommodate for the perinatal transition, as we will see. And then from a cardiac standpoint, you have left ventricle hypoplasia as well as hypertrophy of the right ventricle due to increased afterload. And then also a component of impaired coronary perfusion, which adds into the pathophysiology of CDH. So clinically, this translates into poor ventilation at birth due to the airway hypoplasia. The rigid, stiff the stiff pulmonary vasculature leads to poor oxygenation and pulmonary hypertension, and the heart, the heart failure leads to systemic hypotension, and that leads to failed perinatal transition as well as respiratory failure after birth, and in death in more than 30% of infants. So we'll briefly go over this. So in terms of prenatal management, we'll just talk about what's out there, how it is done, and then look at the treatment as well. So the diagnosis and treatment. In terms of prenatal diagnosis, you can see on this ultrasound, you see the heart beating in the chest, and then you have the left lung up here. But you can see that the stomach is at the level of the heart where it shouldn't be, so into the chest. And so most infants that have CDH, about 2/3 are diagnosed before birth in Western situations, in Western countries, so Europe and the US, I should say. When that diagnosis is made on ultrasound, typically we're able to assess the severity of CDH. So the way it is done is you get a view of a four-chamber view of the chest, which you can see here on this little image. And then you measure the contralateral lung area at that level. So that area is then compared to the circumference of the head, and that gives us the lung to head ratio. And so, given that a fetus morphologically evolves throughout pregnancy, with the head being bigger in the beginning and smaller relatively at the end, there is an observed versus expected ratio, meaning that the observed is what we measure and the expected is what the norm is in normal infants for any gestational age. So that allows us to get a sense of how severe the CDH is, and actually correlates pretty well with postnatal survival. So the observed over expected lung to head ratio in combination with the presence of liver herniation is able to predict survival. And we have those categories of CDH severity, the extreme cases of which almost none make it, the severe and then moderate and mild CDH phenotypes. And that's all based on prenatal screening, diagnosis. Another modality is MRI. Now, that has been used to measure the total fetal lung volume. And again, we have an observed versus expected ratio that is able to predict the severity of CDH. Now, there were studies done comparing the accuracy in terms of and like the accuracy of prenatal lung hypoplasia estimation between comparing MRI versus ultrasound. And so from those studies, we know that ultrasound in experienced hands is as good as MRI, is definitely not inferior. So ultrasound in experienced hands is the way to go for most centers. In general, so the IFMSS, which is the International Fetal Medicine and Surgery Society, established some criteria to think about fetal surgery, so prenatal interventions. And so 5 of them were clearly drafted out in their position paper, which was published in the 90s. But so first of all, you need an accurate diagnosis, which we just talked about. We have an accurate diagnosis prenatally on ultrasound and MRI, and a severity assessment. Second is a well-documented natural history. And so in CDH as well, that it clearly is the case. We know what happens with lungs, with the lungs and over time if we don't intervene, as well as what happens to them after birth, so the survival correlation. And then you need a rationale for prenatal intervention, and that in CDH was stolen from another congenital anomaly, being laryngeal atresia, in which a very high occlusion of the airway led to extremely hyperplastic, massive lungs in those fetuses. And so the initial investigators thought about using this principle and transposing it for CDH to try and obtain lung growth. So that was then trialed in sheep, in which surgically, and CDH was created surgically. The hypothesis was validated in preclinical models. And then the last thing, the criteria that they established was that these kind of procedures need to happen within the boundaries of clinical trials at fetal centers of excellence that are highly multidisciplinary. So this actually is done clinically. So this is the fetal endoluminal tracheal occlusion, in which a balloon is placed into the fetal trachea to occlude and prevent egress of lung fluid that is produced by the lung and achieve lung growth over time. And so that is had actually been done. I mean, so it shows that the lung grows over time. And then two randomized controlled trials that were mostly done in Europe, investigating FETO, so the balloon occlusion in moderate and severe infants with CDH, types of CDH, showed that there was a benefit in survival. However, the Achilles heel of the whole technique, was shown to be prematurity. So, given the breach in the fetal membranes, the placental membranes, did cause an increased incidence of prematurity. So classically, so the balloon is placed around 27, 29 weeks and then removed after at 34 weeks if the baby is not born by then yet. And that's to allow for a recovery of surfactant, which is subdued with balloon continuous occlusion of the trachea. So this is a little video on what the materials are. So it's all introduced over a wire. So this is the balloon. So you can see it's all, yeah. And then introduced through this scope, which is used to one of the highest volume centers for this fetal intervention. So you can see the port going into the abdominal wall of the mother. Voilà, and we'll retract the scope out of the trachea. Well, and so the reason I wanted to show this is just to have an idea about what is possible, and also like to keep thinking about what other things there are that we can do prenatally to improve postnatal outcomes in these kids. Well, next we'll talk briefly about the perinatal management, just trying to drive home some of the key principles. Um, this diagram goes back to the three major components of the pathophysiology. So the pulmonary hypoplasia, the cardiac hypoplasia and dysfunction, as well as the pulmonary hypertension or the increased vascular resistance in the lungs. And so the key things are to, first of all, get gastric decompression, put in an orogastric tube to decompress the intestines. Intubate early and adhere to the principle of gentle ventilation, which we'll discuss a little later. Aim for pulmonary vasodilation if indicated, if there is clear pulmonary hypertension, and then provide some hemodynamic support to support mostly the failing left ventricle. And so I left those the perinatal predictors of survival. So the APGAR score, which isn't used that routinely anymore, but it's still a clinical score that is used quite often. It correlates very well with survival as well as birth weight and the first blood gas. But then the key thing is to obtain an echocardiography in those first 48 hours to evaluate for pulmonary hypertension and left ventricular dysfunction. One other thing that is done perinatally is delaying the umbilical cord clamping. And the rationale is, and this is investigational, I mean, there's been preclinical studies in sheep that show pretty promising results. However, the clinical studies are still ongoing. But the rationale is to wait to clamp the umbilical cord until there is a solid, there's consistent pulmonary ventilation that is obtained to avoid the massive abrupt shifts in circular dynamics, mostly the drop in left ventricular preload. But again, so studies are in sheep show that the pulmonary blood flow is much increased if you wait till hypertension seems to be less if you wait as well. But again, postnatal management, we talked about lung protective strategies, mostly aiming to avoid baro volume and atelic trauma. One way to do that is to allow for hypercapnia to a certain extent, making sure that your pH is above 7.2, but you cannot go up to levels to the 60s and 70s, especially, I mean, in those kids with those very friable lungs. Both conventional ventilation as well as high frequency oscillatory ventilation are used. There's no clear superiority in those between those ventilation modalities. And so they're used, both are used in our ICUs. Talking about surgery, so CDH used to be a surgical emergency. So when there was a diagnosis, people agree that the stabilization immediately after birth is key and takes precedent on surgical repair. That said, the large majority of infants is taken to the OR in the first 24 to 72 hours. CDH study group, their treatments that and showing that 85% of those kids are, of CDH kids are repaired through an open approach, whereas 15% are repaired through a minimally invasive approach. Most of the MIS approaches are thoracoscopic, whereas the open procedures are done through laparotomy. On the right, you can see an ABCD defect score. This is an intraoperative score that is routinely used by surgeons. But so you do that, and then when you use a patch to really recreate the dome about long-term development and growth in those infants to accommodate for. Then, in terms of pulmonary hypertension, so the key in management of pulmonary hypertension is an early diagnosis. Obtaining that echo in the first 48 hours of life is key. And then different strategies are available to reduce the pulmonary vascular resistance. And so on the right, you can see the three main pathways of pulmonary vascular agents. And so one is nitric oxide, endothelin in the middle, and then prostacyclin pathways. And so those pathways act on the pulmonary smooth muscles, musculature. And so the ones that are most relevant, I think, in our context here today is sildenafil, which is basically Viagra, as a PDE5 for to achieve pulmonary vasodilation. Inhaled nitric oxide has also been used. It's very expensive and has no clearly shown benefit in CDH. And then you have bosentan and macitentan and ambrisentan in the endothelium pathways are off-label and are also very expensive for, at least in the US and Europe. And then the prostacyclin pathway, again, very expensive and no clear benefit shown yet, although many studies are being conducted right now. Looking at the cardiac dysfunction, again, the early diagnosis of cardiac dysfunction is key to be able to know and tend to what the cardiac needs are. The key differentiation is whether it's a more right ventricular strain or left ventricular strain or a combination of both that is causing the heart to fail. So in terms of right ventricular strain, that often is because of the pulmonary hypertension, decreased afterload that the right ventricle needs to push against. As in terms of the left ventricular strain, that is most is not entirely clear whether it is a transient phenomenon or whether that sustains itself. And so a lot of people are looking into that right now. Prostaglandin E can be used to maintain the duct open, especially in severe pulmonary hypertension. That is very, very relevant, at least in the beginning of life. And then, of course, ECMO can be considered if the left ventricular dysfunction persists despite optimal medical management. But again, point is the initial echocardiogram is key to treat these babies optimally. Final word about nutrition. So the key thing for nutrition is to start early as you can. Often this is delayed by instability of the infant, surgery or like post-surgical ileus. But the key thing is to keep thinking about it and try and get enteral nutrition going as soon as you can. Up to 10%, more than 10% of these infants end up with feeding tubes for long-term caloric support into adolescence for some of those infants. 40% of those kids are less than fifth percentile. So growth failure really is a key component of long-term management of these kids. Two last slides about long-term complications, just to be aware of what can happen to those kids down the road. Like we're talking about 5, 10, 20 years out of the neonatal period. So recurrence happens in 8 to 12%. There's a higher chance of having a recurrence when a patch is used or when the defect is larger for intuitive reasons. Most of those recurrences happen in the first 2 years of life, but the key message here is if you have a symptomatic child, just get an X-ray to try and think about potential of recurrence. Bowel obstruction also is part of the postnatal follow-up. So they can have either bowel obstruction due to recurrence or adhesions from that initial surgery, or a component of malrotation that can all lead to bowel obstruction. Finally, GERD or gastroesophageal reflux disease is very common. A lot of kids are on PPIs, but also making sure that the initial neonatal positioning and the feeds that are thickened are key components of trying to combat the GERD after birth. And then up to 30% require surgical fundoplication. Now that data is a little outdated as people are doing less and less fundoplications, but these are numbers that were cited in the literature. And so contributing to the GERD are the abnormal anatomy, the motility that is changed in the esophagus, as well as different pressures due to the abnormal formation of the diaphragm around the esophagus. And finally, so pulmonary function. So these kids end up with long-term chronic lung problems such as asthma, reactive airway disease, exertional dyspnea, as well as frequent respiratory infections. So we routinely advise them to get the vaccines for pneumo, like all the lung infections. Infectious organisms. And then 10 to 20% have persistent pulmonary hypertension after the first year of life. And actually, that turns out to be one of the most important predictors of the quality of life of the infant, but as well as the quality of life of the families. And then from a neurodevelopmental standpoint, 25% have cognitive, language, and motor delays, and routine screening for those delays, as well as early intervention with physical therapy and occupational therapy, seems to really help improve functional outcomes. And last but not least, 50% of those kids will have thoracic asymmetry, 20% will end up with significant pectus deformities, and 30% has a clinically significant scoliosis, which is something Dr. Antil studied and published on. And then, again, because of a combination of both tension on the diaphragm, which can be due to the patch repair, but also like the incision used if it's true thoracotomy, and the inherent, like the pulmonary hypoplasia also has a detrimental effect on chest wall anatomy. So that wraps up just a general overview of what CDAH is, how we tend to think about it before birth, immediately after birth, and then in terms, a little more out from birth. And with that, I think I'll hand it back over to Dr. Antil and Dr. Kao for the next part of this seminar.
Thank you so much, Dr. DeBee. Thanks, Felix. That was absolutely wonderful. Just a few comments, and then I think what's going to be really helpful is just looking at some of the radiographic techniques as you indicated how important those are as we think about being able to predict how these babies are doing, and in certain contexts, of course, eligibility for advanced support such as ECMO. I think, a few topics that we can certainly return to based on interest from the audience that you mentioned. One would be timing of repair. Um, and as we've shifted away, as you mentioned, from understanding this as a surgical emergency to really focusing on the pulmonary hypertension secondary to the hypoplasia. So we can talk a little bit more about that, how trends have shifted. And along with that really comes the interesting discussion around ECMO for these babies. Certainly, this is something that we frequently do in the United States. Other contexts, Canada and some parts of Europe, are less enthusiastic about that sort of support for severe pulmonary hypertension. And so happy to talk about the use and decision making around escalation to ECMO support. And that raises a whole secondary line of questions about timing when on ECMO. The trend, in brief, has been to move from delayed repair, um, which the justification was allowing those lungs to get better, as well as to try to minimize bleeding risks while anticoagulated, to early repair. As we know, these babies can become quite edematous, and we have good management strategies for perioperative systemic anticoagulation, pausing and restarting. We can certainly talk a little bit more about tracheal occlusion and where that's going. Um, while there's some controversy, or at least mixed results around where those studies are being done, in particular the US versus Europe. And a lot of that has to do with the neonatal advances in neonatal care and use of ECMO, which may mitigate some of those benefits that we see from occlusion. And then other interesting topics include the type of repair, whether patch is necessary versus muscle flap. Felix has done some work on that with some of our colleagues in Philadelphia and Salt Lake City. And of course, one of the most important aspects of long-term management of these patients is not just ECMO or not just fetal intervention, but thinking long-term. And Dr. DeBee very nicely alluded to the complex neonatal care that these babies need long-term, managing their pulmonary disease, closely monitoring their neurodevelopment outcome. I was able to work on several projects tracking these outcomes in our population in Philadelphia, and certainly warrants very close monitoring and intervention to help these children and their families catch up. And then, of course, surveillance program for the musculoskeletal deformities that they can develop. So all of those are very interesting and could take up the whole time just talking about any one of those topics. So my gratitude to Dr. DeBee for an excellent overview. And I think at this point, we'll have Dr. Cow go over some of the radiographic work that we so heavily rely on. And then hopefully we'll have a lot of time left for some discussion of any of these points.
All right. Can you guys hear me?
Yes.
Great. Perfect. So yeah, I'll take a brief moment to look at some of the complex imaging that goes along with congenital diaphragmatic hernias. As Dr. DeBee and Dr. Antil alluded to, these are very tenuous patients in utero as well as in the immediate neonatal period. I'll also show some limited images on follow-ups in terms of complications and fake outs that can we commonly see. Right. Let's see. Sorry. So in terms of prenatal ultrasound, Dr. DB alluded to these measurements and images in utero. The things that I really look for in terms of the prenatal ultrasound is the first screening ultrasound anatomy. Ultrasound is performed at 20 weeks in the United States, and that usually catches most of these congenital diaphragmatic hernias. The clues that you have if you're performing these yourself are going to be your heart orientation, your stomach orientation, and your liver location. Um, I want to make a note of this image that I'm showing. This is just an example image of a congenital diaphragmatic hernia, and it's very subtle finding sometimes if you don't know what you're looking for. And the reason for that is because when you have a decompressed stomach or lack of any fluid-filled structures, it's really hard to discern what types of soft tissues you're looking at. So this is actually going to be beating. So you know that's the heart, but it's a lot of times indiscernible what tissue is lung here, what tissue is liver, and what tissue is kidneys down in the abdominal cavity when you don't have a stomach to orient yourself. So just be careful when you're looking at these. Um, when you are looking at these on cine, you will be able to have real-time imaging and see the heart beating there. And will hopefully slow that down a little bit here. This is a similar image to what I'm looking at here, and you can actually see various vascular structures entering from the abdominal space into the thoracic space. You can track that as the portions of your portal vein. So you know already you have, if you don't have a stomach, you're looking at portions of liver herniating up into the chest. Here we actually see the gastric lumen right down there. So this is how you kind of orient yourself. And your first clue that you're dealing with a congenital diaphragmatic hernia. Similarly, as I can pause it right here, you can tell just based on these still and movie images, the heart is significantly deviated to one side of the thoracic cavity. That implies there's a lot of abdominal contents herniating up into the chest. And just for comparison, we have fetal MR with these, and you can see this dark material here is the fetal liver. This is the soft tissue on ultrasound that we were looking at initially. There's some additional fluid now in the abdominal cavity, and I'll get to that in a second. This dark structure centrally here is the heart that was so deviated on the ultrasound, and this is a small amount of pediatric lung. So this is what lung would look like, this less gray image, the less gray material on fetal MR. So on MR, you're getting a lot more soft tissue differentiation. On ultrasound, it's hard to see that. So that's what you're going to be correlating for. Um, Again, just to hit on stomach and heart location, your first clue when you look at the trans image is going to be your heart being deviated off to one side of the thoracic cavity. So here we have the rib cage and the bony thorax, and the heart is deviated all the way up to the left here. And this is our gastric bubble here, and there's a lot of soft tissues at the same level of the heart. If you look at a sagittal or longitudinal image over here, you'll see these are the ribs. These individual bright spots are the ribs, and you have a fluid-filled bubble inside the thoracic cavity. That's going to be your first clue that you're dealing with a congenital diaphragmatic hernia when the stomach is up in the chest. The uses for it, as Dr. Dibby nicely pointed out, are you do a lot of this type of imaging on ultrasound and MRI in order to get the measurements that our neonatologists, our fetal surgeons, all of our intensivists need to predict outcomes, right? Estimated fetal outcomes. We do as much as get as detailed images as we can to segment these volumes to give them estimated volumes of what is actually there present in the fetal chest versus expected volumes, and that ratio, as Dr. DB alluded to, has a significant predictor for outcomes. We also note the intrathoracic comments, how much of your stomach is going to be herniated into your chest, how much of your liver is in the chest, and the degree of cardiac displacement. The reason I talk about the degree of cardiac displacement is because a lot of times we'll be asked to look at we'll note incidentally other things, including this particular finding, which is fetal hydrops. So this is all of this dark material. This dark material out in the periphery is the amniotic fluid that we take measurements for throughout pregnancy scans. And here you see this similar dark fluid around the diaphragm, above the diaphragm, lining both sides of the diaphragm. So there's pleural effusions, there's intra-abdominal free fluid. When you're looking at this trans image, you're seeing the liver here in the chest and a lot of free fluid. This is actually the ventral abdominal wall here. So there's a significant degree of abdominal ascites, fluid within the body cavities. So this is fetal hydrops, and this is usually a bad sign on ultrasound ultrasound, as this particular finding is indicative of severe cardiovascular compromise. So once the baby is born, there's a lot of imaging that goes on, and initially, in the initial period before we repair the um, diaphragmatic hernia, a lot of support devices are placed just to keep the infants stable and for them to grow and make it to surgery. Dr. Antil alluded to ECMO deployment, and I think that's certainly commonly seen in certain institutions. However, most of the time, certainly nearly 100% of the time, we're going to be seeing endotracheal tube intubation, umbilical catheter deployment, and some kind of enteric tube deployment in these kids. The value of these radiographs initially is to evaluate the intrathoracic contents if you didn't know where they were before, to evaluate the position of these resuscitation devices, which we do routinely on a daily basis. And kind of the thing I want to note in the next couple of slides in this postnatal period is that the anatomy and the devices are dynamic and they shift around, but the anatomy is also dynamic. So it's hard to make a very specific diagnosis to comment on the severity of the disease on just one particular image, and I'll show you why. Here we have a left-sided congenital diaphragmatic hernia. This is probably the prototypical classic patient we see with the cardiac silhouette deviated to the right, some atelectasis in the right upper lobe, but the right lung mostly formed correctly, and a lot of intra-abdominal bowel containing contents. All these small bubbles of air represent aerated bowel coming up. You'll note, however, the rapogal tube is coming down and entering down here in the left upper quadrant, which suggests that the stomach is actually still within the abdominal space. Note, however, the similar patient, endotracheal tube, you actually have a lower lung volume here with a greater expansion of the left upper lobe and less herniation, and you'll actually see no aerated bubbles up here. This is a herniation of that left lobe of the liver. So just know that not only do you have bowel up there, you can actually have liver herniating up there. I'll note that the stomach here is also herniating upwards, and that can be kind of tricky. Sometimes the stomach is in the abdominal cavity, sometimes it's partially in the thoracic cavity, and if this is decompressed, it's really hard to tell where you are. I will point out also, you can tell that this is actually portions of the liver herniating through the chest because of your umbilical venous catheter is directed upwards and away from your heart. This is an example of the theme I was referring to of things are changing constantly in these kids. So it's hard to localize exactly what you're going to be expecting when you go in intraoperatively. This is the same patient, 1 day apart. You see the endotracheal tube and a enteric tube coming down the esophagus, stopping right here. This patient actually has a left-sided diaphragmatic hernia. However, it's all white in the left hemithorax, so it's hard to tell exactly what's going on over here. This position of the rapogal tube directed inferiorly could suggest, or one could mistakenly interpret this as directed towards the stomach in the abdominal space. However, a day later, with more air in the abdomen, you can tell it actually fills up most of the left chest cavity. So a little bit deceptive in terms of what these patients' underlying anatomy is. So likewise, this is a right-sided congenital diaphragmatic hernia. We know these are less common, and we're commonly taught that the liver is actually a little bit more protective in terms of how much amount of abdominal tissue is herniated into the chest. So this is a fairly mild case where you actually see the dome of the liver, a pretty sizable right upper lung component up here that and normal appearing left lung. You know the liver is herniating up here as the umbilical venous catheter is directed up towards the right shoulder in this direction, away from not coursing back towards the heart. So I just told you that the liver is protective. And so here's some examples when it's not, right? The degree of and size of these diaphragmatic defects does have a significant a determination on the outcomes. So here is a right-sided diaphragmatic hernia where almost the entirety of the right lobe and portions of the left lobe, most of the liver is actually herniated into the chest. A lot of our umbilical lines are deviated, and this umbilical catheter is probably not even in the liver. It might be actually low lying at this point. There's significant mass effect on the mediastinal silhouette, and when these diaphragmatic defects get quite large, you can actually see loops of bowel herniating up into the right chest as well. Down here, these are just the similar loops. These are probably dynamic and go up with different motion from day to day. So, in the immediate postoperative period, postnatal period, a lot of the what is aerated is difficult to evaluate. A lot of your lines look really strange and they go into weird places. So one of the problem-solving techniques that I usually recommend to our neonatologists or even our residents overnight is to get the ultrasound, right? The ultrasound has much better soft tissue resolution when you don't have a lot of air in this region, so you can actually characterize what is herniating into what. You can find lines on your ultrasound. You can find portions of liver on your ultrasound. You can actually track your portal vein and your hepatic veins and all the way up into the right chest or into the left chest, and you can actually see peristalsing bowel in your chest as well. So ultrasound is a good problem-solving tool when you're trying to characterize the anatomy of these things after birth, before birth and after birth. So in terms of the post-repair follow-up period, there's the theme here is uh, things will look strange and things will look different over time. So the post-operative appearance, the main thing I want to hit on is that the imaging is variable. So Dr. Antiel repairs these here and knows very well that you can have a very large pneumothorax one day, you can have that can entirely go away the next day and then come back the day afterwards. So that's why frequent imaging is often performed in these patients. Depending on the type of closure, you will actually see different types of surgical material down here. Sometimes it's entirely, if there's no foreign material down here, you won't be able to see any radiopaque densities along the inferior margins of the hemithorax along the repair. If they do, this is usually what it looks like. It's this amorphous white cloudish material. You're almost guaranteed to have a pleural effusion after these repairs as fluid transitates into that potential space, filling in the hemithorax because the lung is hypoplastic. You can have a postoperative pneumothorax that's very common, and that can come and go and recur. I put recurrence here because obviously our repairs can fail, and we do look for that in terms of herniating bowel contents or abdominal contents back into the chest cavity. So here are some examples that I'm showing. This is our prototypical left-sided diaphragmatic hernia with multiple loops of bowel in the left chest. This is the immediate postnatal post-repair X-ray showing the large pneumothorax that's present. These white yellow arrows direct your eyes to this pleural line. So this is the hypoplastic native left lung. The remainder of this space is filled with extrapleural air. That's not unexpected and not a catastrophic finding. So here's a situation which is like a good example of a patient with a large left-sided diaphragmatic hernia with all these loops of bowel in the chest. In the immediate postoperative period, you have these small pneumothoraces that similar to the findings I showed on the prior patient. A day later, a large pleural effusion has come in and filled this this hemithorax, and just showing a little bit of aerated left lung, which is the hypoplastic segment of the lung. And obviously, we would be draining those if this causes some cardiovascular compromise or a recurrent or builds up again. The chest tube would be the surgical option, and they look very good. Once you evacuate the pneumothorax and drain the pleural fluid, you can actually see the compensatory hyperexpansion of that hypoplastic lung. Some postoperative imaging findings can be very confusing, and Dr. Antila and I struggle a lot of times to actually absolutely determine what's going on here. This is an example here of a post right-sided diaphragmatic hernia repair with a small rounded opacity now in the right lung base. The repair down here, this diaphragm actually comes down and the right lung base looks great. In the periphery, we're just not sure exactly what that is. So you can use ultrasound, you can use CT. We opted to use CT in these situations. You can actually see portions of the liver. It still forms a dome-shaped appearance, and it forms a little waist along where the liver used to herniate through, but this small gray region and the fact that this posterior diaphragm was still intact, we speculated that this repair was was more of an eventration rather than a breakdown of the repair. Similarly, you can have abnormal findings post-repair, especially if there's some scarring within that area. So this is an example of a patient following left-sided diaphragmatic hernia repair with these accessory lucencies and linear opacities on the left lung base, commonly seen following repair. The thing that provoked our attention was this rounded lucency in the on the lateral view. These are the rounded lucencies where you worry about bowel herniating back up through a recurrent defect after the repair. However, if you actually closely interrogate that, you'll see that actually a nice curved line, nice preservation of this diaphragmatic loop. There's a small eventration, but this this is not bowel herniating upwards. So this is actually just postoperative scarring. This is an example where you could a pitfall where you can overcall uh, a breakdown of your CDH repair. Uh, Similarly here, this is a good example of a large left-sided repair, left-sided CDH. And on some images, this patient has this eventration with some air underneath it, concerning for possible breakdown. However, on multiple series of images, you actually see that this thing is dynamic and moves with changes in intrathoracic pressure. So this is an intact repair, right? These things are the repair material is not innervated muscle. It's not tense. So any decreases in intrathoracic pressure or increases in intra-abdominal pressure can cause this tenting effect. So just trust your surgeons when they put these repairs in is basically the name of the game. Um, every once in a while, in the short or long term, these repairs can break down. This is an example here that we have on CT of where the left hemidiaphragm is particularly elevated. You can see on the lung windows where you see loops of bowel in the chest cavity. And in this situation, we did question a breakdown of that hernia, mostly because we had prior imaging showing a very nice curved line of that diaphragm. So that's what this was eventually. So that's all I got. Thank you.